Thank you, Hike. Thank you for the opportunity today to share my experience on this topic. I've been working very hard in the immediate dentoalveolar restoration technique for the last 20 years. So my goal with the audience today is to share my experience, to give to them some explanation. How does it work? How we may have the best outcomes in the management of compromised sockets using minimally invasive approach, and in all clinical cases to using autogenous bone graft harvest from the maxillary tuberosity. So we know that everybody know that this technique is a paradigm shift in the treatment of compromised socket and aesthetic zone. For example, this case we have here a defect, a huge defect right here. This is the prototyping. Right after tooth extraction, we harvest bone graft. We manipulate the graft according to the defect size and width and length, and we insert this graft underneath the soft tissue, and we apply, after the bone reconstruction and immediate implant placement, the provisional crown fabrication. And after a couple of months, 3 or 4 months, we may have this kind of outcome, an improvement in the quality of soft tissue and the volume of soft tissue. And you see the image in the right side, the CBCT scan, the bone graft completely remodeled and is still stable. That's the main goal of the IDR technique. And what's my my target with the participants today? To let them know how to manage as soon as we perform the tooth extraction, applying immediate dentoalveolar restoration, we are able to put the implant in the same session right after the tooth was extracted, and then to fabricate the provisional restoration and to perform the bone reconstruction immediately. You see here that the soft tissue doesn't change anything after 3 months, and you see a very nice maintenance of the anatomical contour of soft tissue. Here, one more example. Right after we did the tooth extraction, you see the implant is already in place. We left the right gap to be grafted. Right after we graft this gap using autogenous bone from the maxillary tuberosity. We install the provisional restoration, and a couple of months later, only 3 months later, you see a beautiful soft tissue around this implant. And I will also call your attention to the maintenance of the volume of soft tissue. But how we may have this kind of outcome, it all depends what kind of material we put inside the gap. And for sure, according to our principles, according to our protocol, we always use autogenous bone graft harvest from the maxillary tuberosity as the main donor graft area. So after 3 months, we insert the final abutment, the zirconia abutment in place, and you see here the maintenance of the leveling of gingival margin. And through this occlusal view, you can see the improvement in the quality and mainly the soft tissue thickness. We have on the right side, in number 8, 3 or 4 times thicker than the natural tooth, talk about the soft tissue thickness. So we deliver the final restoration, the porcelain restoration, over this customized zirconia abutment. And you see, after 15 years, what happened with the soft tissue? We have the tissue shrinkage in the neighboring teeth, in the natural teeth, and we have the maintenance of the gingival architecture at the implant site. That's the main goal of the IDR technique, to keep the soft tissue exactly in the same position. So the question is, are you happy with the management of your patients related to the treatment of compromised sockets? And if you need to face with some scenario, what would you prefer? To work with extraction socket right after we perform the tooth extraction to do the bone reconstruction and everything in one single shot, or would you prefer to extract the tooth and to wait a couple of weeks or months and then to start the bone regeneration, bone and soft tissue augmentation? And you see here two different scenarios. Which one do you prefer? Let's evaluate just a kind of warm up in our presentation today. Let's evaluate this very challenged clinical case. You see that the upper left central incisor is condemned to be extracted. I'm going to introduce this case. The patient lost completely the buccal wall, the palatal wall, and the crestal bone ridge between the central and the lateral incisor in the left side. You see through this 3D image the big challenge that we may face. And how can we treat this case? It was missing completely the buccal wall, and we also lost the crestal bone between central and lateral incisor. And have a look at the palatal aspect. We have no bone. And how can we manage this? As you see the image in the right side, it's missing the buccal and the palatal walls, and you see the prototyping, just a confirmation that the buccal and the palatal wall was gone. So this is what we call the IDR next level. This is the new way to manage compromised sockets in a very tough situation like this. But if I ask you, what are the treatment options when you are facing with a scenario like this? Maybe we can do the tooth extraction plus the tissue granulation removal and wait a couple of months. And then to perform vertical and horizontal augmentation, either using Urban's technique or Curry's technique. And the third surgery for implant installation, maybe 2 or 3 surgeries to manage the soft tissue loss and to improve the keratinized tissue and the papillae creation. 1 more surgery for implant uncovering. So we are in 5 or 6 surgeries. And how about the soft tissue healing if you think about the change in the gingival architecture position along the months and along the years after we perform 5 or 6 surgeries? And what do you think to deliver in the final restoration and final porcelain crown with artificial gingival tissue? Or maybe we may think in one more aspect. How much does this treatment cost for the patient? And what would you prefer if it was in your mouth? A single crown or artificial porcelain gum besides the final porcelain restoration? One more question. What about the predictability of this treatment if you are thinking about the best position of the gingival architecture ever? But the question is it possible to manage this case in one single procedure and without opening the flap? Yes, it is. Let me summarize what we did here. We performed the tooth extraction. We installed the implant fully guided. We harvest connective tissue graft from the maxillary tuberosity. We harvest also bone graft from the same donor area. And we performed the soft tissue reconstruction and the bone tissue reconstruction. After we finish the reconstruction, you see here that we did the bone and soft tissue reconstruction plus immediate provision plus implant installation. And you see here that we construct the provisional restoration with ideal emergence profile, and we install this provisional restoration over the implant. The primary stability should be at least 30 Newton centimeter in order to allow us to perform our provisional restoration immediately. We perform the final suture, and you see the outcome after a couple of months. After 3 months, we have the soft and hard tissues completely healed. What we did? We did the scanning, and we delivered the final restoration, a porcelain restoration with ideal emergence profile. And you see here the CBCT scan before and after we delivered the final restoration. The buccal wall was back, the palatal wall was back. So we have the bone completely remodeled and is still stable around this implant. So look at the quality of the soft tissue, this new peri-implantar tissue, and look at the quality of the maintenance of the volume of soft tissue around the crown. And also pay attention to the soft tissue at the papillae position between the central and the lateral incisor is back in its original position. So this is before and after. You see that we have a symmetrical gingival margin in the beginning, and now you can see the leveling of the gingival margin, and now the leveling of the papillae position. Make a comparison with the right and the left side. This is what the patients are really looking for. To perform a very tough treatment like this in one single shot without opening the flap, this is a completely flapless surgery, applying minimally invasive procedures. So the IDR technique became a 360-degree technique using a full digital workflow. We've been working with this technology for more than 10 years. This is my Instagram. I would like to share with you at José Carlos Martins da Rosa or at Rosa Educação. But look at this clinical case and what's happening here. Here we have a fixed prosthesis from the right canine to the second premolar. In the second premolar, we have the presence of the infection due to the root fracture. In the first premolar zone, we have the tissue shrinkage. If we remove this fixed prosthesis, you see two different scenarios. What's the main difference between these two different areas? We have a healed side and post-extractor socket. But in the healed side, we have the loss of volume of soft tissue. According to what we learned in the last 20 years, a post-extraction socket would never become an edentulous site for late implantation. It's because of what? It's because it would increase the number of the procedures, the cost and the treatment time, and of course, the unpredictability of the outcome. That's why I suggested you that everything is going to be solved in one single procedure without open flap. And just to keep in mind that the dentist is responsible for the decision-making, never the patient. In the second premolar zone, the patient lost completely the buccal wall, and since 2006, our dream came true. We developed the IDR technique to manage this challenge clinical case in one single session without open flap. What's the main concept of this technique? To use the best bone graft ever. The bone graft harvests from the maxillary tuberosity. So this is the concept of this technique is a bone grafting at the time of immediate implant placement and provisionalization in compromised alveolar sockets using a graft harvest from the maxillary tuberosity. Our goal is the preservation and regeneration of the natural biology. This was our first IDR clinical case. You see a big fistula can be seen in the upper right central incisor. What we did here, we did extraction, we evaluated the dimensions of the defect, we installed the implant in the right position, we left the right gap at the facial aspect of the implant, we performed the bone reconstruction using bone graft harvest from the maxillary tuberosity. After we insert this block bone, we fully fill this gap with particulate bone harvest from the same donor side. We install immediately provisional restoration, and here we see the outcomes after 4 months. The soft tissue is being maintained in its original position. So after 4 months, we did impression and we delivered the final restoration, the porcelain restoration. And here we see the clinical follow-up and the CBCT scan. I'm going to call your attention to the buccal wall is completely remodeled and is still stable. And much better than that is the maintenance of the gingival architecture in its original position. That's the main goal of the IDR technique. But the IDR can be applied using a fully digital workflow from planning, surgery, and the follow-up. Look at this case. The upper left central incisor was condemned to be extracted due to the root fracture. Here we see just a confirmation that the buccal wall was gone. We evaluate the thickness of the soft tissue. You see here around 0.5 millimeters in thickness only. What we did here, we did the 3D digital planning. We installed the implant in the right position using a guided surgery. As soon as the implant is already in place, as you can see here, we perform the bone reconstruction using, for sure, autogenous bone graft harvest from the maxillary tuberosity. We install the provisional restoration, a mild provisional restoration immediately. And a couple of months later, only 3 months later, look at the quality of this new tissue, this peri-implantar tissue. If you make a comparison how everything started, we came from 0.5 millimeters in gingival thickness, and now you can see more than 3 millimeters in gingival thickness. That's the main difference between IDR technique and the other techniques available in the literature. So after 3 months, we did the scanning and we delivered the final restoration with ideal emergence profile. And now you can see the outcome, the final crown in place. And now you can see the follow-up after 2 years and the maintenance of the volume of soft tissue around this final restoration. And now you can see the balance between the lips, the gingival architecture, and the final restoration. So what aesthetic outcomes do patients want? What they are looking for? First of all, to mimic the nature. If they lost the bone, we are going to use autogenous bone. If they lost soft tissue, we are going to use autogenous soft tissue. So the last time that we opened a flap to treat a case like this, it was in 2006, almost 20 years ago. Since then, we've been using minimally invasive approach, a flapless surgery, mainly using guided surgery to install the implant in the correct three-dimensional position. And look at these two different cases. In this case, we only use a bone tissue, bone graft. And this, another one, we use bone and soft tissue graft. There are so many indications for bone or bone and soft tissue graft using IDR technique. Only harvest bone from the tuberosity area. So look at the outcomes after 3 months. Look at the quality of this peri-implantar tissue. But let's focus on the main reason of using this technique, to perform a peri-implant soft tissue biotype modification. We change completely the scenario in one single surgery with predictability. If you see these two central incisors, the natural central incisor at the implant side, if you focus on the periodontal biotype, you see that in the right side we have a thick periodontal biotype, but in the left side we have a thin periodontal biotype. Let's see one more example of using IDR technique to replace two central incisors. And let's focus on the gingival thickness. We have again, in the implant side, two thick periodontal biotype in the right incisors. In the central incisor, sorry. In the neighboring teeth, we have a thin periodontal biotype. And how about this case? We perform IDR technique to replace 4 incisors in one single shot, one single surgery. And let's focus again in evaluation of the periodontal biotype. And again, we have a thick periodontal biotype around implants and thin periodontal biotype around natural teeth. That's the main difference and the main advantages of the IDR technique to be applied in your daily practice. If you focus in these two different scenarios, we have the same issue. The upper left central incisor was condemned to be extracted, but in the upper case, we use only biomaterial. In the lower, we use autogenous bone tissue. And you see here, the case that we only use biomaterial, you see here the soft tissue shrinkage. The case that we only use autogenous bone graft, you have the soft tissue maintenance. Look at this and just realize the difference between this outcome and this outcome. But always is related to the what kind of graft you are going to use in order to restore the defect. For sure, we only use autogenous bone tissue. This is the immediate dentoalveolar restoration concept. This is a minimally invasive approach. This is a flapless surgery, but all credits go to the mother nature. We take advantages on bone biology. We harvest bone graft from the tuberosity using chisels, and we use this bone as a biological membrane to restore the wall that the patient had lost, plus particulate bone to be used as a bone filler. And immediately after that, we deliver the provisional restoration. But the question is, what's the importance of using a graft as a natural scaffold filled with osteoblastic cells and growth factors? Look what is missing here. It's missing completely the buccal wall. And now you can see here the thickness of the new buccal wall using autogenous bone graft from the maxillary tuberosity. And our target is to use this block bone first as a biological membrane to prevent cells competition between hard and soft tissue. And then after that, after we insert the block bone, we pack particulate bone as a bone filler. And immediately after that, we install the provisional restoration. And this is what we are looking for. A couple of months later to have a bulky soft tissue around the implant. And you see here, after the same case, after 10 years and before, make a comparison before, and the same dimension, the same thickness that you can see after 10 years, you see in the day of the surgery. So we didn't lose volume. We didn't lose 0.5 millimeters and the bone thickness in 10 years. So also I would like to call your attention that the bone that was placed above the head of the implant remodeled above the head of the implant. So I can state that the bone determines the gun position. How about IDR science, the IDR based on evidence? We have already published 35 articles about this topic. Our first edition of our book was published in 4 languages. We have 2 articles that were recently accepted for publication, and we wrote 14 book chapters and different main authors worldwide. So we have lots of literature about the IDR technique. This is the new edition of the IDR book that was recently published in English language by Quintessence. This book was completely updated, new protocols, lots of new information, and lots of new clinical case. So this is the post of the Quintessence publisher in Germany in the beginning of March about the top 10 book, the top 10 best-selling English books in 2024, and our book is in the 2nd place about the best-selling English books, and this is the Immediate Dentoalveolar Restoration book. So let's focus a little bit in the clinical application, and let's start talk about cases that present the same level of the gingival margin, make a comparison with the opposite side, using corticocancellous block graft harvest from the donor side, the maxillary tuberosity area. Look at this case. This patient, she's a dentist, had an issue in the upper right central incisor, but you still have the balance between gingival margin position. The patient lost completely the buccal wall. What we did, we performed the tooth extraction, apply minimally invasive procedures, and we confirmed that the buccal wall was gone. We installed the implant in the correct dimensional position, and we left a gap around 3 millimeters at the facial aspect. And we manufactured the provisional restoration using the same crown from the patient. We just relined the cervical area with composite resin. We checked this provisional restoration over the implant. We also checked the occlusion. We cannot leave any contact with the antagonist arch in this provisional restoration. And we left what we call a soft tissue gap. This under contour at the facial aspect in the mesial and the distal direction for soft tissue ingrowth. This is the article that was published by our team in 2014, more than 10 years ago, and we launched this way of managing the gap. What we believe in. 3 millimeters works much better than 2 and 1 millimeter at the facial aspect. This is what I recommended to use this very simple mathematical rule. The implant diameter should be equal to the buccal palatal distance of the socket minus 3. 3 it's a fixed number that never changed. So to harvest bone graft from the maxillary tuberosity, we need previously a clinical assessment, X-ray, and the CBCTs from this donor area. So we went to the donor side, we raised the flap, and we used chisels to harvest bone from the tuberosity area. The chisel has to be placed as perpendicular as possible to the bone structure. Right after, to go deepen inside the bone, we can control the length of the chisel inside the bone. After we go into the planned length, we fracture the bone, and we are going to use this block bone to restore the buccal wall that the patient had lost, as you can see right here. And we also match the cervical area of the this block bone with the outline of the gingival margin in order to restore the build, to rebuild the bone architecture. And we fully fill this gap with particulate bone between the cortical cancellous graft and the threads of the implant. And we left bone graft 1 millimeter over the implant platform. We installed the provisional restoration at the same time as we always do in our daily practice. So look at this illustration, just realize what we did at this point. We have already inserted the implant in the correct dimensional position. We manufacture our provisional restoration with ideal emergence profile, screw retained, and we did the bone reconstruction using cortical cancellous block bone graft to restore the wall that the patient had lost, plus particulate bone that was used as a bone filler. And then how about this concave contour in my provisional restoration at the buccal, the mesial, and the distal direction? This is what we call a soft tissue gap that's going to be filled in 5 minutes with blood clot, blood that comes mainly for the graft. So between 1 and 3 months, what we are expecting? First of all, the autogenous bone graft remodeling process, and also the peri-implant soft tissue biotype modification. So this is our dream after 3 months to have bone completely remodeled and still stable, and improvement in the soft tissue in thickness. So this soft tissue gap that we left intentionally, we are going to obtain over 3 millimeters in gingival thickness after 3 or 4 months, or along the months and along the years as well. So this gap was left for soft tissue in growth. And for sure, the main reason was to obtain a thicker peri-implantar new tissue, soft tissue. So what happened with the soft tissue? After 2 weeks, the soft tissue has been changed in the corneal direction. So we wait for 3 months. After 3 months, we push up the soft tissue a little bit more to the apical direction in order to balance the leveling according to the opposite side. We added composite resin, 0.5 millimeters a week for 2 or 3 weeks. As soon as the gingival margin is the same level of the opposite side, we wait a couple of weeks, 2 weeks more, and then we remove the provisional restoration and we evaluate the maintenance of the papillary height position as in the same level of the opposite side. And you can see here the maintenance of the volume of soft tissue, this peri-implantar tissue. So we install the final abutment, a zirconia abutment over the implant, and we deliver the final cemented porcelain restoration. And now you can see the outcomes after 6 years. What would call your attention here? The maintenance of the volume of soft tissue, the papillary height position. But look at this. This is the new buccal wall, completely remodeled and still stable. That's the outcomes that can be achieved only using autogenous bone graft harvest from the maxillary tuberosity. So I can say that if we have around 3 millimeters of bone at the buccal aspect, we do not need to compensate with soft tissue. So this is the follow-up after 13 years. So the gingival architecture is being maintained in its original position. And we still have the balance between the lips, the gingival architecture, and the final restoration. This is what the patients are really looking for. So this is the CBCT scan that was taken after 13 years. And you see here the buccal wall completely remodeled and is still stable. And here you see the 3 steps: before treatment, 6 years follow-up, and 13 years follow-up. And I would ask you, what these 2 images have in common? Everything. Because we didn't lose, it's almost the same image. And it's because we didn't lose any millimeter of the bone in thickness and height. So we have the maintenance of the thickness and height of the bone grafted. Here, I would like to share with you some challenges that you may face in your daily practice. Let me explain one by one. The first one, we have a huge infection in the upper left central incisor and a huge lesion. It was missing completely the buccal wall. The second one, you have this lateral incisor condemned to be extracted. But the question is, how to stabilize the implant in a very tiny bone like this in order to put the implant in place, to make my provisional restoration and bone reconstruction simultaneously. This next clinical case in the premolar zone, we have no buccal wall, no palatal wall, and it's remaining only the sinus floor. This is a periodontally compromised patient. There is no buccal, no palatal, no mesial, and no distal bone ridge in four incisors, sorry. And this, the fifth clinical case, you can see here the presence of the infection, gingival recession, and severe bone loss. And the last one, we have no crestal bone, no papilla between central incisors, and no buccal wall around these two central incisors. So, but all these 6 scenarios can be treated applying the IDR technique without open flap. This is our daily routine in the management of very challenged clinical cases like this. So let's go from the dream to the nightmare. So I would like to share some of this clinical case today. The first one, the first challenge clinical case is this one. And the question is, how to improve implant primary stability in case with low remaining bone, apical bone, and severe bone loss. Look at this case. This lateral incisor presents a huge lesion, huge loss from the middle third to the apical third. And the right canine, we have the gingival recession. If you see this 3D image, and if you pay attention in number 7 and number 8, we are in trouble. Why we are in trouble? Because we have a huge lesion between central and the lateral incisors communicating each other. So you have a tiny bone, tiny remaining bone at the apex. And there is the partial loss of the palatal wall as well, as you see in this 3D image. And this is the size of the defect around number 7 and number 8. Let's have a look at this short video. Let's pay attention right here. The lesion is going to come and it's going to reach, this is the lateral incisor, and is going towards to the number 8. Look at the communication between the lesion from lateral and central incisor. So what are the treatment options? What would you do? So maybe we can do only the tooth extraction number 7. Maybe we can do the teeth extraction number 7 and number 8. Number 3, we can do the endodontic treatment in tooth 8 because it's still vital. Soft tissue healing, if you go and we extract only, doesn't matter, one single tooth, number 7 or number 7 and 8, where the soft tissue is going to stop, we will expect huge change in the gingival architecture position. And which way to go? Am I able to perform this surgery using flapless procedure, or do I need to raise the flap? We need to perform vertical and horizontal bone graft augmentation. How about the apical bone repair and number 8, only using biomaterial? And how about soft tissue graft? Do I need soft tissue graft or not? Or maybe we can go to Maryland Bridge and to finish this case the easiest way possible. No. What we did, we performed the tooth extraction. We removed all this granulation tissue and the apical part of number 7 and the number 8 as well, using very smart tools, very smart serrated curettes in order to reach the apical part of this huge defect. So this is the size of the defect. It seems that we have a huge ghost just laughing for us. And just to keep in mind that we have a very tiny bone at the apex, how to stabilize an implant right now. So we use this very simple mathematical rule to select the correct implant diameter. And here, as we have the 6 millimeters of the buccal palatal distance of the socket, the implant diameter should be narrow, around 3 millimeters in diameter. So we went straight forward to the tuberosity area and we harvest bone and soft tissue using chisels. We harvest bone graft, and using blades, we harvest connective tissue graft from the same donor side almost at the same time. So after that, we perform the 3D alveolar reconstruction. First of all, we insert a buccal block bone graft to restore the wall that the patient had lost, and then particulate bone graft that was used as a bone filler. So we pack bone from the bottom to the top, from the coronal towards to the apical direction, and then from the distal to the mesial direction in order to reach the apical part of number 8. And then we perform the site preparation using ossidification concept with no irrigation, slow speed rotation between 100 and 200 RPM. And we are evaluate the gap to be left at the facial aspect of my future implanting position. We are expecting to leave around 3 millimeters gap. So this is before and after site preparation and after bone reconstruction. Can we use this approach with biomaterial in order to stabilize the implant and to perform everything without open the flap? For sure not. It won't work. So that's why autogenous bone graft is the key in order to succeed with this very challenging clinical case. So we insert the implant and we reached and we achieved a primary stability of 40 Newton centimeter, and we packed more bone above the head of the implant, 1 millimeter above the head of the implant. And we made our provisional restoration with ideal emergence profile. The implant was placed in the correct three-dimensional position, and we stabilized the tip of the implant in the native bone at the apex, but the most body of the implant was stabilized in the grafted area. So during the site preparation, we expanded the bone using ossidification laterally and also vertically. And we also added a little piece of cortical cancellous block graft in order to increase implant primary stability. So this is one more advantages of using graft harvest from the maxillary tuberosity. We may increase, you had no idea how can we increase the implant primary stability using bone graft. So we use here the tunneling technique, and we added connective tissue graft harvest from the maxillary tuberosity to recover the gingival section in number 6. And we apply flapless surgery for hard and soft tissue reconstruction, 100% of flapless. So after 3 months, after hard and soft tissue is being healed, you see here a very nice peri-implantar tissue around number 7. And here you see a very nice thickness of this peri-implantar tissue. And here one example of the biotype conversion. We started with a thin periodontal biotype, and now you can see a very thick periodontal biotype. So we did one more scanning. We delivered the final restoration, a milled porcelain restoration with ideal emergence profile. So this is their X-ray that was taken 3 months after the procedure was finished. And you see here what's happening at the apex. We have the bone repair at the apex, and we keep this tooth still vital. So this is the post-op, the follow-up after 2 years. This is number 8, before and after. Look at the bone repair at the apex. That's incredible, but that's true. That's our life when we use autogenous bone graft from the maxillary tuberosity. And I will call attention to the maintenance of the bone graft completely stable beyond the apex of number 8, and the maintenance of the thickness of the bone graft as well. And how about number 7? Look at the thickness of the new buccal wall, completely remodeled and still stable. We are not talking about magic. We are talking about biology. And the bone graft that was placed above the head of the implant, remodeled above the head of the implant. That's the main difference between the IDR technique and the other techniques available in the literature. It's predictable, it's minimally invasive, we can deliver the provisional restoration immediately, and the patient is very happy because only one surgery is enough to manage, regardless of the extension of the bone defect, regardless of the severity of the bone loss. So this is the post-op after 3 years. The gingival architecture is being maintained, and this is the 3D image before and after 5 years. You see here that the bone completely remodeled and is still stable around this area, the new bone. And the X-ray, so the tooth is still vital, number 8. The bone repair is absolutely fantastic at the apex of number 8, and we have the bone stability around the implant in number 7. So this is the clinical and X-ray follow-up after 7 years. So I would like to share this paper, this article that was published by our team 2014, more than 10 years ago. We did a research and we evaluate 18 cases. All of them presented total loss of the buccal bone wall in a mean of follow-up of 58 months follow-up. And according to our finds, no recession occurred during the evaluated period, and the mean mesial papillary level and the distal papillary level is likely increase over time. So this is what we've been observing when we apply the IDR technique in our patients. Let's see one more clinical case, one more technical application using a triple graft harvest from the same donor side, from the tuberosity area, for those cases that we have the combination between gingival recession and bone loss. So here you see that we have one of the worst scenarios that we can face. We have the gingival recession, bone loss, and the presence of the infection. And to make our life much more difficult, this patient presents extremely thin periodontal biotype. So a severe bone loss, it was missing completely the buccal wall beyond the root apex. So we did the prototyping, and then over the prototype, we evaluated the dimensions of the defect in height and width. And the day of the surgery, we did the extraction, the tooth extraction. We confirmed that the buccal wall was gone. We installed the implant, and we got implant primary stability of 40 Newton centimeter, and we left this gap in order to be restored. Hard and soft tissue restoration right here. We harvest from the tuberosity area a triple graft, a graft with 3 layers, connective tissue, cortical, and cancellous bone in one single piece, plus particulate bone to be used as a bone filler. So we harvest 2 different grafts from the same donor site. And we start reshaping this graft, manipulate this graft according to the defect configuration over the prototyping. And look at the sample of the triple graft with these 3 layers. If we do, as we did, histological section, we can clearly see the connective tissue layer, the periosteum, the cortical, and the marrow bone. So we have 4 sources of the nutrition ready to be transplanted from the donor side to the receptor side. So what's the ideal position of the triple graft after this graft was manipulated according to the defect configuration? What's our goal? To match as much as possible, in the best way possible, the graft configuration according to the defect configuration in all aspects, hard and soft tissue. So we insert the triple graft with the connective tissue layer turned towards the soft tissue and the marrow portion to the implant body, but in between, I would recommend you to add particulate bone as a bone filler. This is what we did here. We have the triple graft inside here and particulate bone. And we installed the provisional restoration immediately. The graft was stabilized using sutures. After 3 months, look at the quality of this peri-implantar tissue. If you make a comparison in the day of the surgery and before, and here I would like to share with you one more example of the biotype conversion. We had in the beginning extremely thin periodontal biotype, and now you can see a thick periodontal biotype. So let's focus in the ideal relationship between the emergence profile and the soft tissue. Look at this configuration of my final restoration being in place. This is the mesial distal direction with under contour, yet the buccal direction, another under contour. We always recommend you to leave a concave contour in order to have much more soft tissue in thickness. So you see here, right after we deliver the screw retained final porcelain restoration, you see the maintenance of the volume of soft tissue. This is the correlative dimensional position of the implant. So this is 100% flapless surgery using triple graft from the maxillary tuberosity. And this is the post-op after 10 years. We have the gingival architecture is being maintained in the same position that we had 3 months after the surgery. And look at the new buccal wall completely remodeled. Look at the thickness of the buccal wall and look at the thickness of the soft tissue. And the bone that was placed above the head of the implant remodeled above the head of the implant. And we have only vital bone tissue in the most important phase of my implant, the buccal aspect. So this is before and after. You see here the improvement in the soft tissue position and the bone tissue position. So let's have a look at this case, the last clinical case to share with you today. This case presented loss of the papilla, loss of the crystal bone, and loss of the buccal bone wall. So this patient came to us. We have the loss of the papilla, loss of the crystal bone, and huge difference between the current gingival architecture and the original one. And our goal is to pull the soft tissue down. But this patient with a high smile line. So what are the treatment options? Maybe we can extract the teeth. The second surgery, bone reconstruction, GBR, for vertical and horizontal augmentation. One more surgery for implant installation. Number 4, soft tissue graft, maybe 2 or 3 to improve the keratinized tissue and the papillae creation. Number 5, implants and covering. We are talking about 5, 6, 7 surgeries. And how about the conditioning of the gingival architecture with the provisional and the final restoration? Do you think it's enough in order to deliver for the patient the gingival architecture in its original position? And how about the predictability? And if you focus on the change in the gingival architecture position, and how much does this treatment cost? So we went in a completely different directions. First of all, we did the extrusion of the right central incisor. After that, we did extrusion in the upper left central incisor. 9 months since the beginning, we have the end of the first stage. So the orthodontic treatment lasts 1.5 years. But we still have the crestal bone deficiency between these two central incisors. We have a relevant change in the position of the gingival architecture. But despite we have a good amount of available bone in both tuberosity, these two central incisors present total loss of the buccal bone walls. What we did in this case? First of all, this is an old clinical case. We did an impression, and over this stone cast, we manufactured the provisional bridge and the surgical guide, and we also did the customization of the new emergence profile. Yep, nowadays, everything is gonna be done using the digital workflow. So let's see some short videos just to realize what we did. So first of all, we confirmed that the both buccal wall was gone. We struck this teeth as traumatically as it was possible. We did the site preparation and implant installation to put those implants in the correct three-dimensional position. This was the guide that we used to perform the site preparation. Immediately after the implant was already in place, we made my provisional bridge with ideal emergence profile. We harvest bone graft from the right tuberosity using chisels. We manipulate this graft according to the defect configuration and replace these two walls with 2 block bones to restore the facial walls in these 2 implants. And then we restore and we rebuild the crystal bone underneath the papilla using particulate bone graft harvest from the maxillary tuberosity. As soon as we finish the 3D bone reconstruction, so we restore the 2 buccal walls that the patient had lost plus the crystal bone. When we finished the bone reconstruction, we install immediately the provisional bridge, as you can see here. So this is the post-op after 3 months. If we make a comparison the day of the surgery, you see it's very easy to realize that we have the maintenance of the volume of soft tissue. So this is the X-ray before and after 4 months. We have the bone stability, the mesial distal aspect, and this is the new crystal bone completely remodeled between these 2 implants. So let's focus on the periodontal biotype. In these 2 central incisors, we have a thick periodontal biotype. In the neighboring teeth, we have a thin periodontal biotype. So we deliver for this patient 4 porcelain crowns in the 4 porcelain restoration in the lateral and the canines, and 2 single crowns over 2 customized abutments over the implants. So we check this customized abutments over the implants. I would like to call your attention to the crystal bone remodel above the implant platform, and we deliver the final restoration immediately after we install and we check the final abutments. And here you see from the occlusal views the maintenance of the anatomical contour of soft tissue around those implants. And this is before and after. We have a nightmare in the beginning, a breakdown in the static. Now you can see the balance between the gingival architecture and the final porcelain restoration. So the perfection is in the details. So this is the outcome after. Make a comparison, how everything started. So this is the case that I shared with you before. I'm finishing my presentation. And the question is, do you know a treatment planning simpler, faster, less invasive, more biological, more predictable, and less costly to manage this very challenged clinical case? This is the main goal of the IDR technique, to make it simple and predictable. So IDR is 100% biological. So why to apply the IDR technique in your patients? For many reasons. Let's focus one by one very quickly. First of all, to minimize the number of the surgical procedures, it's because it's a single procedure. Number 2, we can use this graft as a biological membrane to prevent cells competition between hard and soft tissue. Number 3, when we combine it with immediate provisionalization, we are able to promote an acceleration of the bone graft incorporation and osseointegration. When we manufacture my provisional restoration with ideal emergence profile, we improve the quality of the peri-implantar tissue. When we use platform switching implant, we improve the peri-implant bone stability. And when we use ossidification, we improve implant primary stability. So this technique is very simple. It's very simple to be reproducible, presents a high predictability, and it represents low cost for the patient. That's why we've been using this technique for almost 20 years. We are going to focus in the main indications of the IDR technique. For how to manage those cases that we have loss of the buccal bone wall, loss of the buccal wall in the presence of the infection, loss of the buccal wall in large periapical lesion, loss of the buccal wall in gingival recession, small, medium, and large. I'm gonna share with you the treatment in details for all these very challenging scenarios. Loss of the buccal wall, gingival recession, and loss of the papilla. Number 6, how can we manage proximal bone loss between implants and in the natural tooth? And how about cases that present palatal loss? How to manage those cases that we have 360 degrees bone loss around the condemned tooth, 360 bone loss around the implant? How can we manage those cases that needs the installation of the implant in the molar zone at the interdental septum with or without the presence of the septum? How can we manage periodontal patient? And the last, how can we manage those cases that present large incisive foramen? And the question is, are you ready for this? If you are ready for this, I would like to invite you to go to Idea Institute this July for the 4-day IDR course, July from 9 to 12. If you decided to join us in this travel to modern implantology, it will be a great pleasure to welcome you there.